our international partners, and our community partners. Presenters will share their personal journeys, educational backgrounds, mentors, books, and articles that gave inspiration, challenges, lessons learned, successes, epiphanies, life-changing moments, and even the heartbreaks. The series is meant to provide a platform for both presenters and participants to participate in conversations while developing foundational knowledge and exploring best practices for engagement in the discipline of global health. Our next presentation will be on Tuesday, November 5th. And now it is my honor to present Dr. R.T. Headings. Dr. Headings is a practicing orthopedic surgeon in the University of Kansas Health System. He is also director of an international orthopedic trauma fellowship that focuses on alleviating disparities in trauma care throughout Africa. Dr. R.T. Headings.
Hello, I am not Dr. Archie Headings. Wish I was, but I'm Joey Maxud. I'm a second-year medical student. I'm one of the M2s that works with Dr. Headings, along with the esteemed Megan Lemons and passionate Cameron King in the African Trauma Initiative. Here to talk to you all a little bit about road traffic accidents and work-related injuries. I'm going to introduce this topic and then introduce Dr. Headings. So he will be speaking shortly, I promise. So a little bit about trauma. Trauma does unfortunately kill a lot of people. This figure we see here is in 2016, comparing trauma to other causes of death. In 2016, leading to about 5.8 million deaths in the year. And unfortunately, a majority of these deaths are in low to middle income countries. 93% of these deaths are there. So it's not as if this mortality rate is evenly distributed between countries. Unfortunately, certain nations have to deal with the brunt of this epidemic. And while this number is high, let me make this smaller. While this number is high, unfortunately, these numbers are also increasing. The World Health Organization predicts trauma mortality to only rise with a 40% increase by 2030. So for reference, a 40% increase would mean that over 8 million people are dying per year. And it's kind of paradoxical. Actually, we'll come back to this in a later slide. Who is trauma affecting most? While we see certain conditions like heart disease or cancer affecting older patients, trauma specifically targets younger patients, unfortunately, under the age of 45 or 35. So what does this mean? Why is it significant? When you're dealing with death and you're talking about death, it's important to consider, who's dying and the impact they could have had in the future. Obviously, any death is sad, but when you're examining the impact a patient's life could have had, somebody who dies at the age of, for example, 90 years old, didn't have many productive years left in their life, unfortunately. But when you're dealing with death at the age of 30 or 35 or 45, these patients have several years of productive life where they could have had an impact economically or an impact on society. So this is, truly a disheartening age demographic and target audience for trauma to be affecting. So when we're talking about who trauma affects, these younger patients are plagued with disability-adjusted life years. Whether they're dead, whether they die or they don't die, for every one mortality or one death in trauma, we see around 50 people who are disabled in correlation. So although trauma we saw in our first figure doesn't lead to the most deaths per year, it does affect a significant amount of people. It does lead to the most disability-adjusted life years due to injuries. And when we're accounting for disability-adjusted life years, we're accounting for loss of productive life or a hit in the fulfillment of the life you can lead, which is a consequence of impacting this younger patient demographic. And as we've stated, we're mostly talking about low to middle income countries, unfortunately, when it deals to taking on trauma care. And the highest concentration is occurring in Africa. So for reference, can't see my notes here, but we're going to free ball it. For reference, I think there's around 120 million people in Ethiopia with only 2 trauma care centers, was it? While we have 2.2 million people in the greater Kansas City area and 6 where 10 was at trauma centers. So the difference is, it's vast. And when it comes to resources, we're looking at about 10 orthopedic trauma surgeons in all of Ethiopia. When dealing with like 120 million people, and I mean, you can just count more than 10 here at in Kansas City for sure. So, the difference is significant. The brunt of the impact is devastating. When you see like what patients are coming in with most when it comes to trauma, it's going to be fractures. And the outcomes of this serious trauma, when the resources are available, when we have available surgeons, available institutions that can take on these patients, the outcomes can be good, especially when early intervention is made. But when you're dealing with millions of patients and only few surgeons, or institution that's severely bottlenecked by the number of patients they can handle at once, it's incredibly difficult to partake in early intervention and have these outcomes that we're used to seeing here at KMC. So we have this beautiful animation here. I didn't make it, I wish I did, but it's going to talk a little bit, show you guys like an image of the bottleneck that we see in some of these trauma institutions. So majority of these cases are going to be orthopedic trauma cases, about 64%. And then neurosurgery, general surgery, and just other cases make up the rest of the bottleneck at these trauma centers. So what we'd like to see is patients coming in through the bottleneck and making it out the other side with affordable care, good outcomes, and hopefully minimalizing disability-adjusted life years. But oftentimes, this is limited due to the care that some of these centers are able to provide patients, with the rate-limiting step being the surgical equipment, well-trained surgical team, and the design of the facility. Oftentimes, patients, unfortunately, who want to receive care are unable to receive the care due to this bottleneck and end up here on the side. It's not as pretty as it is in this animation, unfortunately. In Ethiopia specifically, where we do most of our research, we try to find out, what patients are receiving care and what patients aren't receiving care. If there's any trend that we can analyze and further understand, that's where some of our research is. But we haven't been able to find a definite answer. What we have found is that it's kind of ironic because patients with higher acuity cases are being admitted and are receiving care, and due to the nature of their problems, their higher acuity, due to the nature of the surgical teams and the equipment and this bottleneck that we see here, the outcomes aren't always as pretty as they might be here in the United States. But the patients with lower acuity cases who are able to wait are sometimes waiting and are not receiving the early intervention. So they are also not receiving the best patient outcomes that they could possibly be getting. So this bottleneck is, impacting cases of all sorts. Clearly. What is our proposal? So the African Trauma Initiative's proposal is to partner with teaching institutions, medical companies, and other organizations to create and this is the key word, is a self-sustaining trauma hospital that's able to take on these cases and handle, high load of trauma patients efficiently with early intervention and successful outcomes. And this is my last slide, unfortunately. You'll get to see Dr. Heddings shortly. Today, we're going to be talking about work-related injuries and road traffic accidents. As you can see by this gorgeous pie chart, road injuries here in the blue make up a significant portion of this chart and is one of the largest contributors to deaths resulting from trauma and injuries. Our speaker today is Dr. Archie Heddings. Not only is he a great trauma surgeon here at KU, but he takes the time to educate medical students and give us opportunities like the one you see right now. He's a leader in the African Trauma Initiative and a leader in the African Trauma Initiative's fellowship that we've been able to start to train surgeons abroad in American education. So without further ado, Dr. Heddings.
Great work, Joey. I am looking for a timer here. What time do we have? I just want to make sure I stop in time.
It is 12:24.
12:24. Okay. Why don't you stop me at 12:45 to make sure we have time for a panel? Okay. the major causes of trauma, the things that kill most people when it comes to trauma, it's road traffic accidents, number one. And then after that, depending on the study you look at and where the study is done, it's either interpersonal violence or self-harm. And then following that is typically falls. And when we're talking about falls, typically a lot of these falls occur from some type of work-related injury. If you're looking at trauma, there's different ways we break it down. In terms of medical professionals treating it, one thing we look at is it blunt or is it penetrating? Today, we're going to primarily be talking about blunt trauma for the most part. But in addition to that, we talk about, is it intentional or unintentional? So self-harm and conflict-related violence, those are intentional type of traumas. That will be our next discussion, or one of our next discussions coming up. Today, we're going to deal with unintentional type of trauma. So how can a university create positive change in the arena of trauma? So it's really interesting. When Joey was going over this, the conclusion that Joey came to me and he asked me was, he said, when I look at all the road traffic deaths that are occurring, it seems like the thing we need to do is teach people to drive safely, use safe cars, follow the speed limit, not walk on the side of the road. You're absolutely correct. But what I said to Joey was, I said, now how can a university affect that? I don't really know. But what I do know is this. What's happening right now is that you have people that are getting struck by cars and they're having various types of accidents and they need care now. And how can we affect that now? And we can have an impact there. We can have an impact there. So, but the first thing we need to do is we need to, if we're going to change, we need to highlight that this problem exists. And that's the first thing we're doing. If you look at funding that's been put into medicine overseas for the past several decades, very little has been put into trauma. So we need to highlight that this problem actually exists and that fixing this problem, it's an investment. It's not a cost. And I think if you looked at those numbers in terms of disability of life years and who's dying, it is an investment. If you're saving the lives of mothers and fathers and you're making those people productive so they can support their families, that's an investment. So when we talk about road traffic accidents and work-related injuries, this is the heat map. We showed this in our last lecture. And this heat map on the left, it basically shows the highest concentration of motor vehicle accidents tend to occur in Africa. And then on the right, it shows the highest rate of work-related injuries and deaths occur in Africa. So we talked a little bit about that. What is occurring here? Well, I've got two graphs up here. What the numbers tell us, let's bring Carolyn in, is that if you look at this top number here, starting at about 2007, what is this showing? On the left side of that graph, it's showing the total number or total amount of roadway in kilometers. And then this is showing the year. So starting about 2007 in Ethiopia, they had a dramatic increase in the number of roads and their total length of roads. So if you look at this from 2007 to 2018, roads, the amount of them dramatically increased. And then look at this below, number of road traffic mortalities. Those also dramatically increased. They went together, okay? That's not so unusual. You would expect as you increase the amount of roads that the amount of road traffic fatalities would occur. But they're occurring at a rate that's much higher than we would expect as if it were in a Western nation. So what's occurring there? This right here just shows the Belts and Road Initiative, which is an initiative by China to increase the number of roadways and railways and maritime passageways to deliver goods to and from China. I do not want to say anything bad about China. We work with Chinese physicians here. I have some really good friends that are Chinese physicians. They've given me gifts. I love working with the Chinese. And the Chinese have been very good at producing goods. If they're going to produce goods, if you read about this, if you're going to produce goods, you have to have resources, right? And if you need resources, they're not all in China. And so they have to have ways to get their resources in to make these goods. And then if they're going to deliver their goods, they have to have ways to deliver them. So this is just their strategy as a nation for taking something that they do very well and getting the things they need to make it, and then also getting their goods out to the rest of the world. So, and here's Ethiopia. You can see they've helped make this railway from Addis Ababa to a port in Djibouti. And then there's a proposed pipeline here of natural gas that they're going to take about 4, about 80% or whatever of the natural gas that's produced here will go to this port. They plan on using that. But this is an agreement with the Ethiopian government. But what has resulted from this, it's called foreign direct investment. They've poured a lot into the Ethiopian economy to help make these roads. They're not the only ones, they're just the major players there. To make these roads, to get resources out, as well as to deliver resources through within. Okay. So you have a rapid expansion of the roads. All right. And who is affected by this? If you have a rapid expansion of the roads, you're making a lot of jobs, right? In order to have people, to make those roads, and those people have to be transported to and from those jobs. But at the same time, you're also having this nation's producing goods, and they're also harvesting their own natural resources. You saw there's a natural gas pipeline that's going in, and Ethiopia produces a lot of gold. So you have all of these jobs being created. You have roadways rapidly being made, but then you have people that need to be transported to and from their jobs. And what is the solution for this? Well, you can see here, this just shows a good example of how a lot of people are transported in many African nations. This isn't in Ethiopia. This was given to me by one of my last fellows. I believe this is in the Congo or Zambia. But you'll see pictures like this throughout Africa, where you have people that are being transported to and from their jobs on a daily basis, and this is how they're getting there. Well, who do road traffic accidents primarily affect? Primarily young men. The major killer of young men in Africa, it's road traffic accidents. That's what it is. At least that's what the numbers show. And you can see how that can occur. If you have all these people piled into a vehicle like this, and then it gets in a road traffic accident, that's a tremendous amount of trauma. If that happened in America, that would overwhelm one of our trauma centers. And you've got a place that has much fewer trauma resources than we do. And the way these jobs are set up, in the words of my former fellow, Dr. Kendra, if any of you saw his lecture, is what he would say is these workers typically make enough just to survive for a day. So they go to work, they get paid, and that's enough for them and their family to eat off of for that day, but then they have to go back the very next day. If they don't show up, they don't have enough to support their family with. What do the numbers tell us? If you look at the numbers that we have in terms of road traffic accidents, in particular in Ethiopia, and this comes from a United Nations study in 2020, we get most of our data on road traffic deaths from their police, from the police officers or police systems. And those numbers are about 6 times lower than what the World Health Organization actually expects is occurring there. Because if somebody dies, at least at the time of the United Nations report, if somebody dies in a hospital, say 2 weeks after a road traffic accident, it's not recorded as a road traffic accident death. The way they define a road traffic accident is you have to die on the scene, and it has to be reported by the police officers. And even then, if somebody dies in the hospital from a road traffic accident, one thing the UN report said, a lot of times those aren't even reported because the police aren't aware of it. So if you look at that heat map and you think with those numbers that we have, which we think are 6 times lower than what they actually are, they still lead the world in road traffic deaths. That's how many people are dying from road traffic accidents. Now, why are there so many road traffic accidents? I could talk to you about that, but I think one of the best ways is one of our first fellows, Dr. Solomon, took me on a drive through Ethiopia, and he just kind of walked me through this. I think if you watch this, you'll understand why there's so many road traffic accidents. Dr. Solomon, what's it like driving in Ethiopia?
Wow, very difficult driving, but you have to be cautious and fast, very fast, because you see a lot of car coming and the people are also going here and there. Look.
Yeah. Are there no crosswalks?
Yeah,
There's a crosswalk.
there is a crosswalk, but they don't follow the principle of traffic. Simply they came and they challenge you. Yeah, interesting.
What about stoplights?
Oh, stoplight, no stoplight at all here.
Stop signs?
You see, I haven't seen here.
You haven't seen a stop
I
sign here?
haven't seen. Have you seen here?
What about a yield? Is there a yield sign?
Yield also. Here is not available. I don't know. The stop sign is removed by sometimes by hooligans.
Hooligans, right?
Yeah, remove the stop sign. They remove
There's a
it
deal,
and
yeah.
they sell it. This one, roundabout.
What about speed limit signs? Are there speed
Speed
limit
limit.
signs? I have not
Now
seen-
I am driving less than 20, you see? Even not 20, no, 0, 15. Look, the guy is in front of us.
Yeah, he's got to move quick. He's got to dodge.
He is dancing.
He is.
Huh?
No speed limit sign, no stop sign, no yield
No
sign.
stop sign. So this is the problem of the car accidents are very high.
It makes sense. I mean, that's why we see
Yeah.
like
yeah,
that 10-year-old girl who got struck by a car.
Yeah.
See, they challenge. That is good. They're challenging
Yeah.
us.
Yeah.
They want to. It's kind of everything here is a game of.
But now here is a little bit, there is 40. The speed should be 40 here.
That's 40. That should be 40.
But
Through here.
we are going with 10.
Okay. Yeah. And there's a taxi.
Yeah.
And
taxi
there's a
stopping,
bus.
The bus.
Yeah.
See, people just walk down the center of the street.
So all those people are waiting for
Yeah.
the bus. These gentlemen, yeah, that's
No,
how you just
people-
walk.
yeah, look the people are.
Yeah. Well, I noticed that you walk on the roads here because
Yeah, look the people. Yeah.
there can even be a sidewalk,
Yeah.
but people still walk on the road.
Walking in front of you. Without any problem.
Yeah.
So
Okay.
Okay, that's a little comical, but it really makes sense. I tend to think jaywalking rules are a little bit ridiculous until you go to a country where literally everybody jaywalks. And then you see, wow, I mean, it is in some respects a cultural issue. You had roadways thrown down very quickly, and you have a culture that just doesn't understand the implications of not following traffic rules. And literally, if you look at the UN report, there are very few road signs there. The stop signs matter. I mean, it's just these common sense things. But when you put it all together, a lot of cars that aren't safe, no road signage, people that really don't, the laws are not enforced, the traffic laws aren't enforced. It results in a lot of death and disability. And it's true that, I mentioned in there was a 10-year-old girl struck by a car. That's not an uncommon thing. It's the major killer of people, or the major fatality in Addis Ababa is pedestrians getting struck by cars. After pedestrians, the major cause of death from a motor vehicle accident is a passenger, which it makes sense, right? You saw that that truck that was just full of people. There's a lot of people that are going to die if that gets in an accident. So there is so much, there's so many layers going on here that are contributing to all this death. And then when we talk about work, so I'll just play this as I talk. How much time do I have? Okay, so just watch these workers. How is it people, why are so many people getting injured on the job in Africa? You can just, if you watch this, so much of what occurs in work-related injuries are just lack of safety measures. It's just that simple. What you see in lower income countries is richer nations, this has been going on for a while, like to take more dangerous work and just send it overseas. That just seems to be what happens. So, you have people that don't have as much doing more dangerous jobs. And then in addition, when you have an economy that is just exploding like Ethiopia is, or Africa, it's just rapidly industrializing, the bureaucratic system that looks out for the safety of these workers cannot develop at a rate as rapid as these jobs are. And so you have people working in unsafe environments. And there's a lot of data out there that shows that the number of people that have had a job-related injury is as high as 80-some%. or 1 in 3 workers. It's really high. So, and if you look here, it's, there's not necessarily child labor laws. This is a mine. You have children working. I don't know who would want to work in a mine in flip-flops. In America, you have to have steel-toed boots. You have to have all these safety, equipment. Here's somebody working in a mine barefoot. I don't think my feet could tolerate that. I want to just talk about my feet could not do that job. But these individuals do it every day. Here's workers that are several stories up. This is very unsafe. This is why we have so many falls, right? So these are the conditions that are driving this trauma epidemic. What is jointly contributing to the death of both of these? So this is a really big problem. We have to get personal protective equipment for people. We need a good occupational safety and health administration. We need workers to understand the implications of them not using, safety equipment. All these things need to be accomplished. I don't know how to do that, but there is something I do know how to do. There's something we know how to do in this room who work in medicine, right? And so what is jointly contributing to death and disability due to trauma from road traffic accidents and work-related injuries? Here's another video that I think will just illustrate that for us. So we're just going to take a walk through a trauma emergency department in Ethiopia. Let me make sure I'm up.
Starting from see. This is a whole patient or ortho patient?
This is your orthopedic
Yeah, orthopedic patient.
emergency ward.
Yeah,
And all these people are waiting for surgery.
yeah, waiting for surgery. You can talk.
And they're all,
Yeah,
these are
all-
all like
all.
femur fractures.
Femur fracture, pilum fracture,
fractures.
pelvic fracture, every fracture.
How long,
Huh?
how long have they been here? Some of them.
more than 20 days, 30 days.
than
We can
20
ask them. ለስንት ጊዜ ነው የቆያችሁት እዚህ እናንተ? ለስንት ጊዜ ቆይታችኋል ሆስፒታል ውስጥ? For how long they keep here? ለስንት ጊዜ ቆይታችኋል?
ለምሳሌ አንድ ሰው እኔ 15ኛ
15 days? 5 days? ሌላስ? 4 days? 22 days?
22 days.
Yeah. This one, a surgeon came from America, so he wants to see something. ከአሜሪካ ነው የመጡት አንዳንድ ነገር ማየት ፈልገው ነው እንትን ለማለት
22 days, what does he have?
ምንድን ነው ስብራቱ? ሜቢ ራዲያል ነርቭ ፍራክቸር።
Okay.
ኦኬ ከ22 ቀን በላይ አለ እዚህ ላይ ከ22 ቀን more than 22 days 15 days more than እሺ two months he came for checkup. Okay ምንድን ነው ስብራቱ? ምን where the fracture almost 2 months.
What do you have?
I think that makes a point. I could show you more. You're in another country when you see somebody who's waited 2 months and they look as calm as they are. Americans wait 2 hours and they're, it's just, this is not, it's amazing the tolerance that these patients demonstrated. So there is a danger when it comes to dealing with this problem and being academicians, and that we want to gather a lot of data. But what is real is that these people are suffering right now. I would like to have lots of data in terms of the exact injuries that are coming in and the demographics in terms of the age and the mechanism of injury. But there's some data that we can get from this that we can have a response now that has a huge impact. And we can gather data as long as we in the process of implementing these changes. And one way to do this is just looking at their workflow. The workflow proves that the system is overwhelmed and needs to be changed. I don't have to have the absolute number of road traffic fatalities. I don't have to have the absolute number of work-related injuries. I just walked through there and I can tell you that this hospital system is overwhelmed. Now let's look at the workflow. Because if you want to make impacts, we need to change that workflow, right? So we'll just go through the workflow really quick. How much time do I have? 2 minutes. We're going to bring up Dr. Beza and Connie Arnold for a group discussion, but here we are. We have an open tibia fracture, which, if you remember from our first lecture, 80% of the time is life-threatening. And it needs immediate care. What is their workflow for that? Road traffic accident with an open tibia fracture. There's 3 places it can go: to the Abbott ED or a trauma center ED, to the Abbott clinic, or to an outside hospital. Each of these are hours to days: to the ED, to the outside hospital, or to the clinic. From the ED, if you have an available OR, an implant available to do the surgery, and you've got a bed on the floor to take the patient, they can go to the operating room. But if one of these criteria is not met, is there a bed in the emergency department? If there's no bed in the emergency department, they lay on the floor. The floor. The concrete floor. If there is a bed, they can sit in the bed and they can wait. And then you saw the numbers, days to weeks, they can finally make it into the operating room or go to the ward and wait days to weeks and make it into the operating room. If they go to an outside hospital, you can see they can either go to the Abbott emergency department from there, hours to days, or they can go to the clinic, days to weeks. And then from there, the process starts again. This is something that by American standards should be in the operating room either right away, as soon as it hits the door, or within 12 hours. And this is their workflow because they do not have the resources to do better. Okay, so let's bring up our panel. We've got 2 on our panel. Dr. Beza is our current fellow. He actually is an orthopedic surgeon at Abbott Hospital in Ethiopia. He recently joined us for our trauma fellowship. Connie Arnold is a workers' comp case manager who helps me get a lot of patients from point A to point B. If you want to have good outcomes with respect to trauma, not only do you need to get people into the operating room, but you have to have good rehabilitative care afterwards, and you have to help that patient navigate the healthcare system. We understand healthcare, but when you have somebody that either has barriers to receiving good healthcare because of just ignorance, they don't understand it, or some type of cultural barrier, this is when a workers' comp case manager comes into play. And it is absolutely essential to getting patients through the system. They don't have this in Ethiopia, and it's something that ideally we would like to develop throughout Africa in order to help their patients have good outcomes. So Dr. Beza, Connie Arnold, do you mind coming up here? And we'll just open up the panel for discussion. Megan Lemons is going to moderate the discussion for us today. Here you go.
I have some prepared questions, but I'm sure after hearing this talking, you guys probably have questions. So I'm just going to open it up to you guys first. We'll start with one of mine, and if you guys think of anything, slide me down and I'll make sure that say that's
You can just hold that. Yeah.
So my first question is, what financial support systems are available for victims of accidents? And how do these systems interact with the public interest?
Most of the therapies I get is from government. We don't have this insurance system, to cover for their injuries. So they just either pay from their pockets. Most of the time, they just pay from their pockets, and it's usually cheaper because the government provides most of it.
Do those funds that they pay allow them to receive the care that you see patients receiving here?
It doesn't cover much because, especially these orthopedic cases, they need gadgets like you expand on the patients, and has to be, filled when the instruments, the implants get exhausted. So there are a lot of times that these things are not available and the government may not them available. So sometimes we don't treat them at all. We just do, I mean, there are patients who need surgery because of these shortages. You don't do it. So they just stay home and get, disabled. In fact, this is like, it's our day-to-day activity. We just treat with what we have. This thing that you see is not that we kind of designed it to treat our patients. It's just we adapted to it, and the workflow is not that much of different from what you have it, but because of the shortage we kind of adapt this and reach this kind of workflow there. So.
Isn't it true, sorry,
Of course.
isn't it true that there are patients who actually get stuck in the middle because if you are someone who's not able to afford, you have to have clearance from a local government office stating that you're not able to afford to have the care. And if you don't have that, you are in just one big lump sum, meaning that you are either able to do it yourself or you don't get the care. And is it also true that you have to actually prescribe the medication or the gadgets for them to bring at times for you to be able to do the even local care, that's true.
Yeah, very true. Because, like I said, there are shortages. And so these people, there are people who just came and they can do about anything by themselves. The government is not going to provide them. They're just stuck there, and they stayed for weeks there. And sometimes the option is going to fall on their hands, either to go home or stay there until the instruments are available. And there are also a lot of times that you just give them the prescription and they have to bring the implants by themselves to the hospital and do it. Yeah, it's very.
So I'm going to ask, so once they make it to the ward and they're admitted and they've had their surgery and then they're ready to go home, who's making sure that they have what they need at home? Their durable medical equipment like crutches, wheelchair, scooter, walker. Where does any of that come from?
You just give them the prescription that what they needed.
And they go somewhere to get it?
Yeah.
And so.
And most of the time, like these rehabilitation centers and everything, we don't have that. So we kind of appoint them frequently so that and give them instruction by ourselves. If they are doing good, they're going to be good. Otherwise, in most of the cases,
so do you have
there are even surgeries that I don't do because I know the outcome is going to be bad. Despite me being the surgery, it won't help the patient at all. Just cripples them more. So because of these things, don't come with them. So that is asking.
So for example, Connie, that's a really good point. We had a patellar tendon disruption that was chronic, and Dr. Beza said he would not do that surgery in Ethiopia because they don't have good care postoperatively. So even though they have the implants to treat it, they don't have good rehab afterwards. So he won't even offer the patient a surgery. So then the patient's crippled, all because of lack of rehab.
Which could be an easy fix to some degree. I mean, if you could give them resources, are the resources there? Do you guys have therapy facilities outside the hospital? Do you have places that you can resource or, guide them to go to, even if they're paying for it themselves? There's no places.
Yeah.
So there's no place for me to navigate them to go to.
Yeah. Usually if you had rehabilitation, like the physical therapy is going to be attached to the hospital.
Okay, so they can come to the hospital.
They can come to that.
If they can get into the therapy.
Yeah, the problem is they are not right away from the hospital. Some of them
live far away.
Very far away.
So.
And they don't come.
So they're not gonna come.
It's very costly. Yeah, it's very far and it costs them too much. They don't come because we are kind of a system that we give the care. It's almost for free. So they can't afford to come here, to come to my facility and get the help
Surgery.
they need. Yeah. So they just don't come, and it's not available everywhere. So it might be available in my hospital, but I mean, it's very hard for them to come and get the treatment. The therapy they needed. Yeah.
Sometimes even if you have the money, you don't have the trained person. Like Dr. Beza may operate on him, and you say, okay, he needs a good rehab. The person has to have your own due diligence, finding individuals that actually can take care of the post-operative rehab. You don't have a good rehab center.
So we had to learn that to rehabilitate them at the same time.
And I apologize, I don't have my watch on me, but if students have to go, don't feel bad about leaving. But we're gonna continue this discussion.
So could there be a way that you could have like packets together that they could at least have the education? That when you do it,
We, for example, if let's say I'm going to treat this unstable type of femur fracture, which needs non-weight bearing, probably prescribe him with crunch and pain medications or antibiotics, then I'm gonna link him to the physiotherapy.
Mhm.
But those kind of things are given by patients, one who can afford them and one who are very close to the hospital. Otherwise, they won't get these things. They just left the hospital when they are discharged and try to figure out what's going to happen by themselves. Even if you give them the prescription of it.
do you have a physical therapist that meets them when they're in the ward to go over the exercise training?
So it's very cumbersome for them. They just only do for patients who are appointed to them. They just don't come to the wards and to the physical therapy.
No, but like here in the hospital here, before a patient's discharge, OT and PT is meeting with them to assess their home needs. You don't have
There's-
anything like that there.
There's nothing.
Yeah, I don't know how I would navigate in Africa. There just was, there's just no resources. I mean, they don't even have a closet. You know how hospitals used to have, I'm an old nurse, sorry. We used to have closets in hospitals where we'd send them home with crutches, walkers, scooters, Do they have anything like that?
Well, we want to get it from them. We do. Actually, we're planning on sending 2 shipping containers. We've already got a lot of these like braces and things that have been donated to us, which is nice. Those only go so far, but you're right, those are huge needs that affect
There is
the
no
out.
hanger rep there, is
There
there?
is not, no, but Don Joy, I'll just throw it, Don Joy has given us just a tremendous amount of braces and crutches to send. So, but that's not sustainable, but it's a start. It's something that we can do. How much time we got, Megan?
We have a couple.
Okay,
We have a question. I had a question from the flow chart, the 3 criteria to make it from the ED to the OR. Is there one of those 3 that they get hung on more, or are they all equal issues?
This,
Yeah,
there are
OR,
times, for
the
example,
implant or warderized.
yeah, if there is no implants, you're going to start there. If one of them is missing, you're going to start at the ED. If there is no bed, we cannot just go home, say go home, go somewhere else. He's going to stay wait on the floor.
on the floor.
Yeah.
The floor.
Yeah. the floor.
This is one thing, when I was talking with him, when we say floor, we mean you're going to unit 43. When he says floor, he means you're going on the floor. Yeah.
Do you have,
But is there one of those that are a bigger issue than others, or are they all equally weighted issues?
They are equally.
Equally weighted.
Yeah, because we don't have 10 years ago, something like that, the national census, the Addis Ababa population is around 5 million. It's like now double, triple. And my hospital is the only hospital, as far as I know, is a trauma center who accommodates, not only in Addis, but all over the country. So when you think of burden is everything, like the patients, ton of patients. We don't have bed for all of them, and we have only in Abbott like 4 OR rooms, and 2 of them are assigned to us, 1 for elective and 1 for emergency. And the emergency table is shared among the other recipients. So imagine we have this amount of patients, but we got to treat and operate only with 1 table. So if there is no ICU, and there are also plenty of sick people, that very sick people who needs, especially post-op, into that which you want to transfer into the ICU. There is no ICU, you don't get treated them, you're literally going to kill them. So yeah, they are almost equally important. Yeah. And there's one thing that's not mentioned, there's so-called waiting list. We have the waiting list. There are patients going to
Waiting for surgery.
Yeah, they're going to wait
Because
for
trauma is a surgical disease, remember. So if you're gonna fix a trauma patient, you need to get into the operating room. So a waiting list for surgery.
So there are patients who are assigned sometimes directly to that list. For example, those patients who need total joint replacements, hoping their service is going to be started. They in the future, they just directly put them there because we didn't start the service yet. There are also patients who stay there because of lack of bed, the waiting list, and because of lack of implants there. So probably not heard of these things, but we have this waiting list, which is crazy.
Get this, how big is the waiting list?
It's like 4,000.
4,000.
Yeah, 4,000.
The waiting list is 4,000. And tell them that story that you told me about when you called somebody on the waiting list to come back for their surgery.
That's very terrible.
But
yeah, when I was a 4th-year resident, the 4th years are the one who calls from the waiting list, and I was about to call the one person who needs this partial hip replacement. So I called the house, and someone answered that the patient already passed away. There are plenty of times who can, yeah.
yeah, and that segues into this point. Trauma systems are effective in saving lives and improving outcomes. And it's estimated that if all-cause injury mortality rates in low to middle-income countries were reduced to the levels seen in high-income countries, more than 2 million lives, 50 million disability of life years, and 786 billion US dollars could be saved annually. It's that point that I said earlier. If you want to make change, you need to first highlight the problem and show that it's an investment and not a burden. And this is an investment. 2 million life saves is not small. And what he's talking about is a hip fracture, which would be treated within the first 24 hours, maybe 48 hours here in the United States. But if treated non-operatively, the risk of mortality is 67%. So, and that's not surprising. So, yes.
So talking about like open fractures and things like that, being on the floor, being like waiting months, it brings the thought of, is there prevention for like infection? And is there a priority list for open fractures? And if so, how beneficial is that? And I guess the second kind of follow-up question is like, how often, waiting that long, do you see patients that had this, perfectly preventable, if it were in the West, end up with like amputation and things like that?
Yeah, we kind of have triage system to prioritize these open fractures. But we have too many of them. So you can like use one emergency table. So you can probably do 3 or 4 during the nighttime, another 3 or 4 during the daytime. You just give them the wound care kind of stuff and put them on antibiotics, sprint them, and they just wait. And whenever there is a chance, you get to operate on them. But sometimes the wound, especially if turns out to be fine, the wound gets closed. It's no longer an emergency. Just treat the complications that they have. Yeah.
So who's taking out their sutures and stuff when you do the surgery? You're sending them and they're going back to wherever they came from and they have to come back in for an appointment.
Sutures, they can get in the local clinics. They are like health centers.
So amputations, I guess they are amputated, there's no resources for them to get prosthetics or,
There is a process, but like still, it's only one place. I think the government is opening another one now. We are doing, I think, terrible on amputations because we don't have this rehabilitating process for them. It's because of the system. We don't have one.
So at your ED, I mean, do you have so I'm used to dealing with catastrophic injuries. So sometimes mine are orthopedic and vascular combined, and sometimes a head injury on top of it. Let's just throw that in there. So are you able to, those people move right up the list, I'm sure, because they're vascular.
Yeah.
When you have those resources there.
Yeah.
Okay.
Yeah. We kind of prioritize life saving.
Mhm.
Saving. But everyone uses their systems, their rights. There is no such thing called less of a treatment.
Mhm.
So everyone needs the treatment they needed. At least that's how we learn it in school. So you just don't give it to them because of shortage of a lot of resources. So we kind of adapted to this one. We didn't make it. We just
Adapted to it.
yeah.
Whereas here we triage and do things a little differently.
What does payment look like pre and post op, especially for patient injuries that aren't emergent or aren't on that prioritized list to go to the ED to wait for weeks? Are they getting access to pain management? And then at home too, they are.
We don't use these narcotics drugs. We usually use these non-steroidals and paracetamol. We use them. Otherwise, because when you put them on those things, you may need to rehabilitate them to get out of it, right? We don't have those systems. We don't want to add another problem to them. So we just give them this, little ones.
Like NSAIDs.
Yeah. And to be honest, kind of tolerate it. Do better with that.
Because they don't know any different.
Yeah.
You're not presenting them with a narcotic.
Yeah.
We're gonna have to call it. Thank you, everyone who came. All our students, thank you so much. We need to let them go. We need to let our students go. For those who want to stay, I'm going to have Connie talk a little bit about what she does. But for everybody who needs to go to get to class, if I need to email a professor, send me, I am happy to do it. Just make sure you're good. Okay, all right. Okay, okie doke. Thank you so much. Thank you all so much. Okay, we'll let everybody clear out. Then I'm just gonna have Connie talk a little bit about what she does. Thank you all so much. If anybody wants to get involved, feel free to email me. I am not the quickest to getting back to you, but I do get back to you. And I will find a way to work you into whatever it is we're doing or whatever project I can get you involved in.
There's a poster outside the door.
Yeah. Yeah.
No, yeah. I'll be here. Okay, all right.
I'm not sure who's that.
Okay, all right.
I'll ask afterwards.
Okay, cool.
Thanks for
You bet. Megan, great job. Joey, great job. Thank you guys so much. All right, we're streamlining it. We're getting better. We could just start on time.
I know, we just Zoom stays to work for once.
Yeah, exactly. Okay, I hope to see you Thursday if you can make it. Okay, all right, you bet. Bye, guys.